next speaker is Lindsay Tards. Lindsay is a pharmacy resident at Methodist Hospital, and she will be speaking to us about semaglutides and the cardiovascular patients.
Okay. Thank you, Carrie. So again, my name is Lindsay. I'm a pharmacy resident at Nebraska Methodist Hospital. And today we're going to be focusing on GLP-1s and their impact on cardiovascular care, mainly semaglutide itself. Okay, so first we're just going to go through some of the objectives today. So we're going to explain the pharmacological mechanism of semaglutide and its role in reducing cardiovascular risk. We're going to explain the preoperative considerations related to semaglutide and cardiac procedures. And we're going to evaluate clinical trials of patients with cardiovascular disease and demonstrate how the introduction of semaglutide has altered treatment strategies, improved patient outcomes, and reduced adverse cardiovascular events. So first, we're just going to get into a little bit of background of GLP-1s itself. So the historical indications for these medications are for patients with type 2 diabetes trying to attain glycemic control and for weight management or weight loss. The mechanism of GLP-1s themselves. So GLP-1 is a gastrointestinal peptide, or what we call an incretin hormone. That's a fancy way of just saying it stimulates insulin release, and they are involved in regulating glucose homeostasis. These are released after the ingestion and absorption of glucose, protein, and fat, and they provide one of the many connections between eating and insulin release. A quick pathophysiology of GLP-1s. So again, after we ingest food, incretin hormones, again, GLP-1 is one of these, along with insulin, are released from the pancreas, and they promote three key effects. So satiety, prevention of glucagon release, and they suppress appetite as well. There's a bunch of different GLP-1 products on the market right now. I've specifically highlighted in red the semaglutide products because, again, that's what we're going to be focusing on today. So we have our once weekly injectables, our once daily injectables, our twice daily injectable, and our once daily oral tablet. And then down at the bottom there, just for completeness sake, I listed the generic names that go with their brand names. A lot of the brand names are probably what most of you guys recognize these by, all the commercials on TV and all that stuff. So now moving to semaglutide itself. Again, historical FDA approved indication of these two injectable medications. So Ozempic is FDA approved for type 2 diabetes. Wegovy is FDA approved for weight management. Both have shown cardiovascular benefit. They are both long-acting medications, so they're titrated on a monthly basis. I've listed some of the common dosages there that are used to titrate between. And then the nice thing about these medications is that they, due to any degree of renal or hepatic impairment, do not need any dose adjustments. So looking at a previous study, we're going to go through a couple studies today, so just bear with me. There's going to be a lot of numbers, but I'll try and explain everything the best I can. So there was a trial that was done in 2021 called the STEP 1 trial. It included about 2,000 participants. Key here is without diabetes. Patients either had to have a BMI of greater than 30 or a BMI of at least 27 with at least one weight-related comorbidity. These weight-related comorbidities being hypertension, dyslipidemia, obstructive sleep apnea, or cardiovascular disease. And they essentially assigned these patients 2-to-1 randomly to 68 weeks or 16 months of treatment with once weekly semaglutide at a dose of 2.4 milligrams or placebo. And again, both of these groups did receive diet and exercise counseling as well. And the primary endpoints that they looked at in this trial were the percentage change in body weight, and then looking for at least 5% weight reduction. They did analyze 5%, 10%, and 15%, but their one primary endpoint was just at least 5%. Results from the step 1 trial, as you can see in red there, I have the p-values from both of the primary endpoints. This just highlights the statistical significance of these results. So for the first primary endpoint, the mean change in body weight from baseline to week 68 for patients in the semaglutide group was negative 15%. So patients lost about 15% of their body weight versus those losing about 2.5% of their body weight with placebo. Looking at the different categories of weight reduction, again, statistically significant for all three different categories of weight. So achieving at least 5% weight loss, at least 10% weight loss, and at least 15% weight loss. So some more results from this trial. Patients who received semaglutide had a greater improvement with respect to cardiometabolic risk factors than those who received placebo. The risk factors that were defined in this trial were reductions in waist circumference, blood pressure, glycated hemoglobin levels, and lipid levels. And the magnitude of the reduction of these cardiometabolic risk factors was directly correlated to the amount of weight that was lost. Adverse events, of course, were reported in this study, most of them being nausea and diarrhea. Not super uncommon that this is occurring with these medicines just because of the mechanism of action. Most of the time when it was reported in this study, it was typically transient and mild to moderate in severity. It did resolve usually within a couple of weeks of initiation. And then just a little snippet of how much it kind of affected patients. So treatment was discontinued in about 4.5% of patients in the semaglutide group and about 1% of patients in the placebo group. So the conclusion that they drew from the step 1 trial was among overweight and obese adults, again, without diabetes, once weekly semaglutide plus lifestyle intervention was associated with substantial, sustained, clinically relevant weight loss, with 86% of patients attaining at least 5% weight loss. They then go on to explain that another trial is to be conducted looking at cardiovascular outcomes specifically, and that is the SELECT trial of 2023, which is what we will be talking about next. So the objective of the SELECT trial was to assess whether semaglutide could reduce the cardiovascular risk associated with overweight and obese individuals, again, in the absence of diabetes. So this study was nearly 18,000 participants assigned 1-to-1 to receive once weekly subcutaneous semaglutide at the same dose as the step 1 trial, so 2.4 milligrams versus placebo. And the mean duration of follow-up was about 3 years for these patients. This study was conducted in over 41 different countries across about 800 different sites. So here I've listed some of the inclusion and exclusion criteria. On the left side is the inclusion criteria. Patients had to be at least 45 years old with a BMI of at least 27. And then as you can see, the three grouping together is the established definition of established cardiovascular disease. So patients with prior MI, symptomatic peripheral arterial disease or prior stroke, any patient with any sort of prior revascularization, so a CABG or a PCI, and then any sort of amputation patients were also included. There's a ton of exclusion criteria. I'm not going to read all of them off, but I've specifically highlighted in red, again, patients who have diabetes or a hemoglobin A1C of greater than or equal to 6.5% were not included in this study. Down at the second from the bottom there, I've listed a couple types of cancers. So that MEN stands for multiple endocrine neoplasia, and the MTC stands for medullary thyroid carcinoma, just two very small subsets of cancers that are a contraindication to GLP-1 usage. So I've listed some baseline characteristics here from the SELECT trial. So about 3/4 of patients were male in this trial. The average hemoglobin A1C for participants was about 5.8, with 64% of trial participants meeting the criteria for prediabetes. Prediabetes meaning their hemoglobin A1C ranged from 5.7 to 6.4, so not quite up to that 6.5. And then of note, most participants in this study were white as well. More baseline characteristics here. I left this in here just to kind of break down kind of some more categories. So the average age, which I forgot to include in here, it was about 61 years old, give or take a few years. The mean BMI between both groups was about 33. 76% of patients did have a prior MI, 23% having a prior stroke. And then down at the way bottom there, you'll see New York Heart Association class 1 to 2 did make up 91% of patients in the heart failure cohort. So back on that exclusion criteria chart, patients in New York Heart Association class 4 were excluded. So there's not very many that were studied in that class 3 category here. So as far as the primary outcome for this study, they were looking at the incidence of major adverse cardiovascular events, abbreviated as MACE. MACE essentially stands for the composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. Secondary outcomes that were assessed were death from cardiovascular causes. There was a heart failure, a composite heart failure endpoint, which included death from cardiovascular causes, or hospitalization, or an urgent medical visit for heart failure itself. And then the third secondary outcome was all-cause death. Super important with this trial is that if the primary endpoint occurred in a lower percentage of patients in the semaglutide group compared to placebo, they then went on to test these secondary endpoints in hierarchical order. So I have them listed as 1, 2, 3 for a reason. So they essentially had to show a lower incidence of the primary outcome to move on to the secondary outcomes. And then within those secondary outcomes, if number 1 did not prove to be significant, they no longer tested the ones following. Looking at the primary endpoint for the SELECT trial, which again was a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. This occurred in about 6.5% of patients in the semaglutide group and about 8% of patients in the placebo group. Again, in red there, I have the p-value giving us a statistically significant result. All of this to say patients in the semaglutide group had a 20% less likely chance to have an adverse cardiac event occur compared to patients with placebo. Now moving to our secondary endpoints, again in hierarchical order. Over here on the left was our first secondary endpoint. This value, unfortunately, death from cardiovascular causes, occurred in about 2.5% of patients in the semaglutide group, and 3% of patients in the placebo group did not yield statistical significance. So they then did not go on to test the other 2 secondary endpoints, the heart failure composite endpoint and death from any cause. They did not test those for superiority over placebo. But looking at the statistics, looking at the hazards ratios and the confidence intervals, you can reasonably assume that they would show statistical significance just based on those values. But again, it was not studied for superiority. Adverse events, of course, did occur in this trial. Serious adverse events were reported in about 33% of patients in the semaglutide group and about 36.5% of patients in the placebo group. Interestingly enough, was statistically significant in favor of semaglutide versus placebo. And then adverse events leading to discontinuation of either semaglutide or placebo did occur more frequently in the semaglutide group. Not surprisingly, though, it mainly was just due to those side effects. So nausea, vomiting, diarrhea, which is very commonly seen with this type of medications. And again, this was the exact same finding from the previous step 1 trial as well. So the conclusion from the SELECT trial, the effects of semaglutide occurred early after initiation of treatment and were directionally similar across cardiovascular endpoints and pre-specified subgroups. The cardioprotective effects of GLP-1s are not fully understood. They are likely multifactorial being associated with multiple changes in cardiovascular biomarkers such as blood pressure, waist circumference, lipid levels, and glycemic control. Semaglutide improved cardiovascular outcomes in this trial, whereas lifestyle and pharmacologic interventions for overweight and obese patients tested in previous trials have uniformly failed to do so. The biggest conclusion from the SELECT trial itself is that weekly subcutaneous semaglutide at a dose of 2.4 milligrams was superior to placebo in reducing the incidence of a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke at a mean follow-up of about 40 months. I did want to talk about a few limitations of this trial. So it did only include patients with pre-existing cardiovascular disease. So we do not know the effects of these medications in terms of primary prevention of cardiovascular disease. And then the diversity of this patient population doesn't necessarily duplicate a globally representative population, as if you recall, most of these participants were men and they were Caucasian. So currently, Wegovy did receive its FDA approval in March of 2024 for reducing the risk of cardiovascular death, heart attack, and stroke in either overweight or obese adults with cardiovascular disease. I do think some further research needs to be done, especially in the heart failure category. If you recall, there was 91% of participants in the heart failure category that were class 1 and 2, and class 4 was excluded. So more research into that class 3, I think, should be done, as well as its use in combination with SGLT2 inhibitors, as those are a pillar of our heart failure treatment nowadays. Now moving on to our final objective, looking at preoperative guidelines for GLP-1s themselves. Due to the mechanism of these medications, there is a potential risk for aspiration. In 2023, the American Society of Anesthesiologists came out with their recommendations. They essentially recommended that patients on daily dosing of GLP-1s should hold this medication on the day of their procedure, and then for patients who are on weekly dosing of these medications, their doses should be held a week prior to their procedures. Again, this is irrespective of the indication as to why they're on it, whether it was weight loss or type 2 diabetes. There's now new guidelines for 2024. These were published by the American Society for Metabolic and Bariatric Surgery. They essentially came out and said that there should be shared decision-making between patient, the anesthesia, the procedure that's occurring, and provider in terms of balancing risk benefit for holding or not holding these medications. They specifically recommended looking at 5 different variables in terms of analyzing the risk versus benefit. So looking at if patients are on their escalation phase or in their titration phase versus their maintenance phase, if they've reached their max dosage and have been on that for quite some time, as the escalation phase is going to be associated with an increase in a delay of gastric emptying and side effects. If patients are on high dose versus low dose, which is very similar to the escalation phase versus the maintenance phase, as high doses can lead to an increased risk of side effects. Whether patients are on weekly or daily dosing of these GLP-1s, as weekly dosing can have an increased risk of these GI side effects as well. Looking at whether patients currently have these GI side effects occurring, and then always looking at other conditions beyond this medication usage that may also cause a delay in gastric emptying, namely one being Parkinson's or gastroparesis as well. So the recommendations from these guidelines is these GLP-1 agonists may be continued preoperatively if patients, looking at those 5 variables from the last slide, are at a low risk of either delayed gastric emptying or aspiration. If they deem patients at high risk, they do still recommend holding GLP-1s, and they then would refer you back to those 2023 American Society of Anesthesiology guidelines as far as holding parameters are concerned. With that, I will take any questions.
How do you see with Zepbound's new FDA approval for OSA? How do you see some of the other GLP-1s going after that? And do you think the insurance companies will ever catch up with the approval process for that diagnosis?
Yeah, so that's a really good question. So as far as Zepbound is concerned, I didn't dive fully into that one. I looked at semaglutide for the most part, but insurance companies are always kind of tricky with these medications. They always, need prior authorizations, and even then, sometimes they don't even get approved, kind of depending on the indication. But I'm happy to get your contact information if you would like, and I can absolutely look into the Zepbound more for you. Yeah.
Thank you.
All right, thank you.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.